Now, the government is injecting over 20 billion rand into the public health sector, a move that includes hiring 800 more doctors. Finance Minister Enoch Godongwana announced the funding boost in Parliament on Wednesday as part of the revised budget dubbed Budget 3.0. 20.8 billion rand will go to the health department over the next 3 years under the medium-term expenditure plan. This comes amid backlash over the failure to hire qualified unemployed doctors, despite severe staff shortages at public hospitals. Joining us now to break this down is Russell Rensburg from the Rural Health Advocacy Project. Russell, thank you so much for joining us this evening. Now, Budget 3.0 finally went ahead with a focus on health for this conversation. What were some of your key takeaways?
I think it's the third budget, and I think it's really a different territory with an adjustments budget in a couple of months. Look, healthcare hasn't really had investment or above inflation investment since at least 2012. And we had sort of a blip during COVID. So I think any increase in the health budget is welcomed. However, given what we face, the 20 billion over 3 years is really not a significant amount of money, given the challenges that are faced in provincial departments of health. In our own analysis, for instance, a large amount of that money is being allocated to the provincial equitable share, primarily to fund a new public sector wage agreement. So very little of the money is really going to be invested in strengthening the quality of services or filling in priority service needs, like, for instance, the recent donor transition, which has left critical programs like the HIV/AIDS and TB programs significantly underfunded. And if we don't do something urgently, we may see a rise in the number of people contracting HIV, as well as those with TB being at risk of dying. We are already losing 56,000 people each year. And in rural communities who are almost completely dependent on publicly funded services, we need to almost have specific priority on those services. Because across all the indicators that we measure at a district level, rural communities do a lot worse, from maternal mortality to HIV retention in care, or even deaths from TB, because we don't even measure at that level. So I think there's a long way to go, and I think these investments are very important in laying a foundation, but we can't continue in business as usual. Something really drastic needs to be done.
And, as you're speaking of a significant amount going to public sector wage as well, one can't help but also think about infrastructure when it comes to public healthcare facilities as well. Has there been enough of a focus on there? Because there's been quite a lot of issues when it comes to infrastructure and maintenance of infrastructure at public healthcare facilities.
Look, I think over the next 3 years, we're probably going to have to take some difficult decisions. There is allocations for the building of another central hospital in Limpopo, right? But I think we need to look at a much broader look at infrastructure. A lot of the infrastructure that we have is quite dated. In many areas, I think we haven't invested enough in maintaining it. We saw most recently with Charlotte Matreke not having hot water as a result, pipes within the buildings not being replaced in a 12-year period, and left us with a 6-week timeline. So if we're thinking about really investing in infrastructure, so one of the things that we need to do is maybe review our current hospitals, figure out which ones are still functional. Maybe we even look at closing some of them down and building new ones that are more energy efficient, that are cheaper to run. I think many of our large hospitals are half empty or half of it's unused, yet we still have to use that infrastructure. So I think there's a lot of innovative thinking required to make sure that the close to 300 billion rand that is allocated to healthcare is utilized in a manner that is efficient and effective, and that waste can be eliminated. Because we're not going to see a massive increase in the resources over the next 3 years. So we need to start looking for creative ways to work with the money better and to use the staff that we do have a little bit more optimally by distributing them to lower levels of care where there's a big challenge.
Now, I don't want to be the bearer of doom and gloom, but when we're looking at how the health department handled COVID-19, for instance, and the massive corruption we saw unfolding there, how much faith do you have that this money that has been allocated will be used wisely and there won't be the wasteful expenditure that we see time and time again?
I think that's a core focus for us. When a lot of the political parties spoke about the elimination of waste, and the introduction of spending reviews. Now, to be fair, the health department wasn't, the corruption, COVID corruption was across government, right? I think a lot of it was linked to the releasing of emergency procurement regulations, and everybody had to buy things. And I think the politically connected people really just abused that. But the health sector itself has some procurement corruption, and I think we can do a lot better in managing that. But for us, something that was missing from the budget was some guidance on these expenditure reviews that all the political parties were talking about. Now, for us, I think it would have been very useful if we had issued some guidelines on how government is planning to approach spending reviews with a view to reducing waste and inefficiency. And by publishing those guidelines for public comment, they can really take the public into their confidence and allow us to start thinking creatively how we can fix our services with the available money that we have. How do we use the HR better? How do we develop better partnerships between ourselves and the private sector in some instances? You know, at the moment, it costs around 700 to 900 Rand per clinic visit, right? And when you look at what we can probably buy that services for half the price in some of these community pharmacies and pharmacy chains like Dis-Chem who are also running clinics. Sorry to plug that. So I think we need to start thinking creatively. How can we use new legislative reforms to better structure the public sector health market? And how can we ultimately just begin delivering the essential health services like maternal and child health, where we have a problem, and with the withdrawal of HIV funds, we could have a risk. Infectious diseases like HIV and TB. TB is our massive killer, 56,000 people a year. HIV is at risk. We've seen the papers, 500,000 new infections over the next 20 years if we don't do anything. And then there's non-communicable diseases like diabetes and injuries from violence, including gender-based violence, that our public sector system is not always well organized to respond to. So I'm hopeful that over the next couple of months, as we start hearing conversations on how we can better structure public services, how we can look at reducing costs, even as costs have reduced for the last 10 years, and how can we lay the foundation for beginning to fix our publicly funded healthcare system for once and all.
You know, when you mentioned that figure as well, quite interestingly, of 700 to 900 Rand per clinic visit as well, the work that you do as the director from the Rural Health Advocacy Project focuses, of course, on the rural areas as well. With figures like this, 700 to 900 Rand, that is not small change as well. How do you find that those that you're working with at the rural level are coping with such?
I think obviously, I know it's a free services. That's what it costs the government.
Yeah.
You know, but the way that we think about healthcare services and where we need to have a lot more health literacy is like when we access care early, you know, then it's a whole lot less expensive. But I think because of a number of different factors, we really delay healthcare seeking, be it to get a TB test when we have the diagnosis, or the symptoms like rapid weight loss, consistent coughs, night sweats. If we get in early, the earlier we detect it and the earlier we go in treatment, the less transmittable it becomes. Or infectious diseases like HIV and AIDS. If we stay on treatment, it's 95, 95, 95. It's no longer a public health threat and you can live a long and prosperous life. But to do that, you need to go for the test. You have to initiate into the care and you have to stay in care. And similarly, you know, every sort of major thing starts off with primary health care with a test. With maternal and child health, for instance, pregnant mothers have some of the hardest journeys through the health system. And I think a lot of that has got to do with delayed access. You know, you should have at least 5 to 6 antenatal visits before you deliver your baby. On average, we measure one. And if we start improving those measurements, invest in on-site community health workers to link people to the system earlier, we can reduce the costs. We can improve the information that we have on the mothers who are about to give birth. And we can reduce the amounts of complications surrounding birth because more information means that doctors are better prepared. But I do think we need to think about that service package for the people at the 80% and not such a big focus just on these large hospitals, which are being overrun often by delivering primary healthcare services, which can be delivered a lot cheaper elsewhere. So it's really about a cultural change. So some of the things that we need to do going forward is really communicating. What are our health priorities? How are we approaching it? We see the whole debacle around HIV funding and the removal of and the transition from a major donor. thanks to we're grateful for the American people for what they've invested in the past. But instead of coming together and figuring out how do we use our collective skills of moving forward, we're planning in silos, right? And I think we're still waiting for the Treasury confirmation on how much they can fund, when they will fund it, and so forth. So one of the things, as our president said in his meeting with President Trump now the other day, is that South Africans we have a problem, we sit down, we have dialogue, we solve it. There's not enough of that happening at the moment. And I was hoping that with the introduction of the Government of National Unity, we would have an opportunity for more dialogue, to have a better sense of what our immediate priorities are in the public service, particularly in healthcare, and then beginning to use the legislations like the NHI to start restructuring the public sector so that we can deliver effective and quality services for people, even in a routine way, like getting your sexual and reproductive health services where you want it, where you need it, instead of standing in line at a clinic to take a day off work when you can just get it in the mall where you work. So I think there's a lot of innovation, but it all starts with building up good data sources, making them public for everyone, and really working in a collaborative way to strengthen this asset that we have. Because South Africa is pretty unique in the continent and particularly in the region to have such a comprehensive, publicly funded healthcare system. But underinvestment made it weak.
Yeah, and just in closing, what did you make of the announcement of more than 800 posts of community service doctors over the next 3 years? I mean, also considering the number of unemployed doctors, some of them sitting at home, and those who are still qualifying. Will this 800 over the next couple of years be sufficient, or will it barely make a dent?
I think any addition to human resources is important. And I think we welcome it, but at the same time, it's also dependent on where those doctors are deployed. There's a massive need in district hospitals in rural areas. We have long relied on community service doctors to fill gaps. We know now that the minister set up a task team to review some of these policies, and there's a risk that community service could be withdrawn. And a lot of those hospitals will be under-resourced. So these 800 doctors can make a significant impact if they're deployed in the right areas. But I would hesitate to say that at the same time, nurses are the backbone of the primary healthcare system. And in the initial announcement, there was a 200 or so allocation for it. But we know almost 2,000 nurses lost their jobs with the withdrawal of USAID. So I think more should have been done to prioritize bringing those nurses back into the system, because they are the front line. Primary healthcare is nurse-led. HIV initiations and care are managed by nurses, and our professional nurses really need a lot more support. But instead, we just focus, we need to have a little bit more balance. I appreciate, and I think it's fantastic that we've added these doctors, but at the same time, I think we need a broader undertaking to see what we can do to strengthen the nursing shortage in our country, particularly in the rural areas where often they're the only health professionals that people get to see in our clinics.
Absolutely. A crucial point to end it on, of course. Russell Rensburg, thank you so much.